So I want to thank the organizers for inviting me to speak, and I will echo Andy's comments that I'm probably somewhere in between. So you're going to see a lot of the same data, maybe with just a little bit of a different bent in terms of my take on it. So I'm arguing in favor of ABVD as the standard of care for patients with advanced stage Hodgkin's. Oops, let's see. Go back. So as Andy already alluded to, the question in my mind, given that the Echelon study at this point has only shown a difference in PFS, is the question of whether PFS is the bottom line in frontline therapy for advanced stage Hodgkin lymphoma. And as he mentioned, the U.S. certainly did not adopt BIACOP despite both an improved PFS and a trend toward overall survival, which is exactly what we're seeing in the Echelon study. So not to go through the details here, but at least 4 or 3 studies that showed a significant PFS benefit. Interestingly, one of them with longer follow-up lost the benefit in the BIACOP. And in terms of the overall survival, again, in all of the studies, somewhat of a trend toward improvement with BIACOP, and yet because of the toxicities, at least in North America, we have not adopted that. So instead, what we have done is use the PET-2 to direct therapy, or the interim PET, following 2 cycles in most cases of after ABVD. And there's really 3 studies that have looked at this approach. So a single-arm study with SWOG that looked at ABVD times 6 in PET-negative patients, and the PET-2 positive patients had 6 cycles of BIACOP. And then the RATHL study, which I agree with Andy is now pretty much the standard of care outside the setting of a clinical trial or before Echelon came along. And in this study, patients who were PET negative were randomized to either 6 cycles of ABVD or 2 cycles of ABVD followed by 4 cycles of AVD. And then I think important not to forget the LISA study, which had both an experimental and a standard arm. But in the experimental arm, patients had 2 cycles of escalated BIACOP, and then if they had a negative PET, which was the case for 88% of patients, they were de-escalated to 4 cycles of ABVD. If they had a positive PET, they continued with 4 more cycles of escalated BIACOP. So in terms of the outcomes on those 3 studies, really highlighted the RATHL study here, which again is pretty much the standard of care. As you can see, the 3-year PFS was nearly identical for the ABVD times 6 versus 2 ABVD and 4 AVD, and the overall survivals for these patients were really outstanding at 97% of patients still being alive in both arms. And in contrast, the LISA study, so 2 cycles of dose escalated BIACOP for everyone, had a slightly, again, can't compare across the studies, but this is really the best overall PFS we've seen in PET-negative patients. For the whole study, it was 86%, which again is better than we've been seeing with ABVD. And this is 5-year follow-up. So these numbers at 2 and 3 years were in the 90s. So just to kind of summarize where we are with the PET-directed therapy then, so our current bar for stage 3 and 4 Hodgkin lymphoma, I would say, is a 2-year PFS of 79%. In Echelon, it was 77%, 82% in PET-negative. And with this approach, 82% of patients can go on to receive 2 cycles of ABVD followed by 4 cycles of AVD. So really minimizing the bleomycin significantly. And then the alternate approach, I think, for these patients would be escalated BIACOP times 2 followed by 4 cycles of ABVD in 88% of the patients. And again, these are the best results we've seen in terms of PFS. And in terms of the toxicity of 2 cycles of escalated BIACOP compared to 6 cycles, which is what most of the other studies use. I think we have a lot of experience with 2 of escalated BIACOP now because of the early stage study where the EORTC H10 study, where patients who were PET positive went on to get 2 cycles of escalated BIACOP. And really, in terms of the fertility, the leukemia, at least in women, I think probably almost no infertility with 2 cycles of BIACOP, probably a low level in the men still, and probably very low risk for leukemia. So, but again, still room for improvement in these numbers. So then comes Brentuximab. So this was the first attempt at putting Brentuximab in frontline therapy, which was in older patients that Andy showed us before have a worse outcome, just using single-agent BV because of the very high response rate seen in the relapse patients, and indeed still, again, had a very high overall response rate of 92% with 73% CRs, but unfortunately, as you can see, very rapid drop-off in the PFS, so not durable. And also what we saw in this age group was a very high incidence of grade 3 peripheral neuropathy, and I think it's important to remember that in terms of the tolerability of BV in older patients. So then the next thing, when they saw the PFS being unacceptable, was they then added just one additional drug to BV in these older patients. And the blue curve is BV plus DTIC, and the red curve is BV plus Benda. And again, extremely high response rates in both arms with high CR rates. And a better median progression-free survival. It was less than a year in BV alone and was about 18 months. And again, these were older patients, most of whom had comorbidities. Interestingly, the BV plus Benda study was closed prematurely because of excessive toxicity. So about 60% of the patients had serious adverse events. And the whole idea of this study was actually to make a more tolerable regimen. So they definitely did not achieve that. So again, I think the BV plus DTIC is an option in these patients, but not ideal. So then on to Echelon, which Andy just did a great job presenting all of the data, so I will try and not spend too much time on this, but again, the study was random assignment to either AAVD versus ABVD. And here is the outcome, which again, I think statistically significant improvement in 2-year progression-free survival, 82% versus 77% with a P of 0.035. And I think under different circumstances, we might have been happy with this, but I think all of us seeing those very high response rates to BV, 85%, that we were, I personally was quite surprised that there was not a bigger difference, that I thought that this would be bigger. And so, again, I think I'm not arguing that it isn't statistically significant in terms of whether it's clinically significant. I think is a different question because we have the whole toxicity issue to address as well. And as Andy said, no difference in the overall survival. Their initial press release did tout a trend, and that AAVD is the blue curve there. And I think we just need time with this, obviously. The current p-value is 0.2, and so it is not significant. I don't even think we can say there's a trend until we have longer follow-up. And then in terms of the forest plot, again, Andy marked the same things I did in terms of the things that were interesting here. So I did highlight the age greater than or equal to 60, where the forest plot shows there was no benefit to AAVD, and I would say that I don't think that that's an acceptable regimen in terms of the way it was given in Echelon 1 with 12 doses of Brentuximab and giving it concurrently in older patients, because it does not look like there was a benefit in the PFS, and those patients do have significant toxicity. So that would be completely off the table for me and a patient in that age group. The North America, he pointed out, which I would just highlight, he showed that slide from the slides from ASCO, and not only was the AAVD arm slightly better in North America, maybe because we'd been using BV longer and we're keeping the doses intense, but the ABVD arm was actually worse in North America than the overall, so it was 73 versus 77 in the overall, which means that in the non-North America group, it must have been 80. So I think that's a little harder to explain, because I do think, at least in my experience, that we do keep those patients on schedule with full doses. And so I think that 11% difference actually works both ways. It wasn't all because the North American patients did better with the BV. And then the high-risk patients, IPS 4-5, the stage 4 patients, and then also highlighted the male benefit potentially. So in terms of the adverse events, I think that in terms of there were more grade 3 events on the AAVD arm, so 83% versus 66%, more hospitalizations, more febrile neutropenia, even in patients who got growth factors, and then significantly more grade 3 peripheral neuropathy, which is really very difficult to function with grade 3 sensory or motor neuropathy, so that is a significant toxicity. And then the one thing that was higher in the ABVD arm was the pneumonitis, 3% versus less than 1%. So then the deaths on study, which again Andy reviewed for us, I would just point out this 11 deaths related to pulmonary toxicity out of the 13 deaths on ABVD, and on the next slide I'll show the other data with ABVD, like in the RATHL study. This is significantly higher than was seen in RATHL, so I think now that we're using ABVD followed by AVD, that the number of deaths on the standard of care arm is likely significantly less than seen in this study. But there were, in this study of more than 1,300 patients, there were to date at 2 years 11 excess deaths in the ABVD arm, some toxic and some progressions. And so this is the comparison of the treatment-related deaths with ABVD on Echelon, RATHL, and SWOG. So on the Echelon study, in the ABVD arm, there were 11, 1.6%. In the RATHL study, on the arm that got ABVD times 2 plus 4 of ABVD, there were no deaths in that group, as opposed to 0.8% in the patients who got 6 of ABVD, but even this is less. And then on the SWOG study, there was only 1 death out of 271 patients. So again, I'm hopeful that as we know more about bleomycin lung toxicity and get rid of that drug, that the standard arm is probably less toxic than it was in Echelon. And then just wanted to point out again the bleomycin lung toxicity in older patients. So there's been a couple of retrospective studies and then some interesting data from RAPID as well. So in a US multi-center study, 92 patients between ages 60 and 89, 32% incidence of bleomycin lung toxicity and 25% mortality among those patients. A French multi-center study showed a 21% incidence of grade 3 and 4 pulmonary toxicity with ABVD in older patients. And then in the RAPID trial, I couldn't find the data about how many patients they had that were 60 or older, but if you just use the sort of epi data that we know, it's probably somewhere around 15% of the patients who are age 60 and above with newly diagnosed Hodgkin's. And of those 602 patients, let's assume that 60 of them had, or 90 of them maybe were 60 and above, and they only had 3 cycles of ABVD, 3 to 4 cycles. There were 6 treatment-related deaths on that study, and here's the ages of those 6 patients. So all 6 of them were 60 and above, and 5 of those 6 were due to pneumonia and pneumonitis. So I think we can say you should not be giving bleomycin to patients over 60, nor do I necessarily think you should be giving Brentuximab as part of the Echelon approach to those patients either. And so in terms of the rough upfront drug costs for AVD plus VV versus ABVD, and I got some grief for this, showing it at ASH last year, but I'm going to show it again anyway, and because now I actually have some backup for it. So if you just use the average selling price, which is an amount that's published and updated quarterly, and estimate a 70-kilogram person, that 6 cycles of ABVD is pretty much what you would call dirt cheap, just in terms of the cost of the drugs, as opposed to the cost of the drugs for AAVD, which, if you take into consideration the BV plus the need for Neulasta, it prophylactically in all of those patients. Then so this just came out like 2 weeks ago in the JCO, and actually was presented in abstract form at ASCO this year. So a cost effectiveness analysis of the Echelon 1 study, taking into account all of the factors: more relapses on Echelon 1, patients having to have salvage therapy, patients having to have transplant, and I don't understand all those analyses, but it looked very complete, and I guess because it got accepted to JCO, someone who knows something must have thought it was a decent study, and that the lifetime healthcare cost per patient with AAVD is $361,000 versus $184,000 with ABVD, and then they use this incremental cost effectiveness ratio, which is about $300,000 per quality of life adjusted life year. And if you look at the literature for what they describe currently as acceptable thresholds for interventions, it's usually in the $100,000 to $150,000 per quality adjusted life year, so it's about twice what we would normally say is okay for that intervention. And they had a very interesting discussion in their paper about using this sort of analysis to determine drug prices, which I thought was very insightful in terms of if the BV price was for this indication, frontline Hodgkin's, was decreased by 56 to 73%, then the incremental cost effectiveness ratio would be in the currently acceptable range. And this number goes up. This used to be $50,000 to $60,000. And so then again, the authors suggest this value, this indication-specific value price drug, which I think is a great idea, will pay whatever it's worth in terms of quality adjusted life years. And so in conclusion, I would just start again by saying if we are basing our treatment decision on PFS, which is where the Echelon was a winner, then we should actually be choosing BIACOP times 2 plus ABVD because they have the best 4-year PFS. And then I think we can't forget that ABVD times 2 plus AVD times 4 is really the standard of care, not ABVD times 6. And so for me, AVD, no bleomycin, remains the standard of care in patients 60 and above, and no benefit to AAVD. And then Echelon, I would just reiterate, again, there is a statistically significant difference, not a home run. I think that there is room for improvement, and I think Andy's data with the sequential BV with only 6 doses is very interesting, and I think we need to reconsider the BV schedule, the number of doses, and that this might be a winner under those circumstances. And obviously we need the longer term survival. If it does turn out to be statistically significant, then I think we can debate again, Andy.